Welcome to UMDF's Ask the Mito Doc monthly webcast. Tonight we will hear from Dr. Amy Goldstein and Dr. Todd Kilbaugh from Children's Hospital of Philadelphia. Our moderator for the Q&A this evening is our very own Margaret Moore, UMDF Associate Director of Support and Education. Let's get started, Margaret.
Hello, everyone, and welcome to February's Ask the Mito Doc webcast. We're excited to have all of you here for this very, very important topic. But before we get started, I wanted to thank our sponsors, Edith L. Trees, Charitable Trust, and UCB, for allowing us to have this great educational content. This is an outreach to the community. If any of you have a child between the ages of 12 and 17 impacted by MELAS, there is a new opportunity to share your patient story and help shape an upcoming clinical trial. If you're interested in this, please reach out to us at www.umdf.org/research, and we will be able to get you more information about that. Of course, you can all reach out to me too. Most of you have my email address. So, well, let's get started. I'd like to invite Dr. Goldstein and Dr. Kilbaugh to join me on camera and unmute your microphones so we can get started. Thank you for joining us today. This is such an important topic for our patient community, and I think let's just get started. Lots to cover today, and we want to have time for questions at the end. So basically, you're going to be doing some Q&A with each other. And answering some questions, and then at the end, some of the questions that will appear in our Q&A feature will be answered. So I'm going to go ahead and get off camera and let you all get started.
Thank you so much, Margaret. And I should be sharing my screen now. Can everybody see my screen? Yeah? Okay. Well, I'd like to thank Dr. Todd Kilbaugh for joining me tonight, and he is an anesthesiologist, an ICU doctor who works with me at Children's Hospital of Philadelphia. And so we're going to jump right into it. And I see that we already have 4 questions in the Q&A. And again, please keep them coming because that's what we're here for tonight, is to help answer your questions. I have a lot of questions myself. And so what I told Dr. Kilbaugh I'd love to do tonight is show him the letter that we give in our Mito clinic to help our patients prepare for surgery and anesthesia and make sure that we're on point, right? Because as we learn and as we do and as our patients go through procedures and we learn from our patients what went well, what didn't go well, we try to change this letter. And so we're going to go through that first, and then we'll see what other questions come up from there. So let me go to my next slide. Okay. So again, this is the letter. It's a little wordy, so I'm going to walk us through it. So first is kind of an introductory paragraph. And again, not everybody who we see has surgery at CHOP. So I do a little introductory paragraph where I say, many patients with mitochondrial disease can generally tolerate anesthesia, but some patients can have hypersensitivity, especially to volatile anesthetics. And therefore, we should use caution on induction. So the introduction to anesthesia as you're first being put under. And so I'm going to outline several general anesthesia recommendations for patients with mitochondrial disease that you, the patient, and the anesthesiologist might find helpful. And then our second paragraph goes into some more information. So patients with mitochondrial disease are more sensitive to physiologic stressors. So what are these stressors? Even minor illnesses, dehydration, fever, temperature extremes, surgery, anesthesia, and prolonged fasting and starvation. And then we want to explain why that is. During such stress, rapid systemic decompensation may occur. So that means catabolism, right? Breakdown of proteins, metabolic compromise can occur. And this can lead to things like problems with the liver, problems with the heart, problems in the brain. So we're telling people, this is kind of the warning, right? We're not kidding around. This person needs to be watched carefully and closely. And if there are stressors, this can put somebody who might look fine over the edge, right? So preventative measures, which is what we're aiming for here, are aimed at avoiding or at least not exacerbating this decompensation. And so when I'm having this conversation with patients or families in clinic, the first thing I say is we need to avoid these stressors, right? So what is the narrowest window we have to be what we call NPO, right? Nothing by mouth or nothing by feeding tube the night prior to the surgery, right? And then if you can't eat any food, well, what's the period of time where you can't have clears, right? And so we really try to get a good understanding from the anesthesia team, how long can we be fed for, and then how many hours does it have to be before we have to stop using clear liquids so that we're not dehydrated going in. One of the questions that I get asked all the time is, does my child need to be admitted the night before? Do we have to run IV fluids all night long? Or do we have to, do anything extra from that standpoint? And this is really a question that I then bring in the anesthesiologist and say, what do we need to do here? And the way that I answer that question is, well, does the child normally have feedings all night long overnight? Or is this usually a child that doesn't eat overnight and is fine with overnight fasting? If this is a child that has a feeding tube and they're usually fed all night long and the team says nothing to eat after midnight, that's a child or an adult that probably needs to come into the hospital. If they're usually fed all night long and now they're being told, no, you can't use that feeding tube for an overnight feed because there might be a glucose issue or some other issue. Now we have a reason to bring that person into the hospital for overnight monitoring the night prior to a surgery. Likewise, if somebody has a fever the day before or that morning, or they're developing a cold, or they have prolonged fasting beyond the period of time that they were told to fast, these now become warning issues. So the other situation that I give is, let's say that you're asked to come to the hospital at 8 a.m. for your surgery, and your surgery is supposed to be at 9 a.m. And suddenly your surgeon has an emergency and they're doing another case, and your particular surgery gets bumped from 10 a.m. to noon to 2 p.m. to 4 p.m. and no one's come to hook up an IV, you're not getting any fluids, you've been fasting all day long. That can be dangerous for a mitochondrial disease patient because now you're really going in, the tank is completely empty. And again, this is something that could be prevented. So what we're trying to do is make sure that not only does the surgery go well, but that recovery goes well also. And so I'm going to pause here. I want to see if Dr. Kilbaugh has any comments or anything to say with any of those points that I just made, any of these kind of stressors or the need to admit overnight prior, or anything, that I've said so far that either is right, wrong, comments, anything like that.
No, I think those are all sort of dead on. I mean, I think one of the main things is that preoperative fasting, just in anesthesia in general, is variable across institutions and across different places. It's probably recognized now that you probably, for solid foods, like if you're going to have a chicken dinner or something like that, it's probably be about 8 hours. But for liquids, it's probably really up to about 2 hours that you have to be NPO. Although that can be very different across multiple different institutions. So I think you have to really check with your institution first to make sure that you didn't go through all of that and show up the day of surgery and then it gets canceled. But I think it's very important to know what your child's feeding regimen is and if they need to be admitted to the hospital overnight for IV fluids. And I would work with your mitochondrial primary care physician to do those things. And anesthesia will work with you and that team to make sure that your child's ready for surgery. I think it's also probably, if it's a, sorry, I have a bit of a cold, but if it's a scheduled surgery, that's something that's not an emergent surgery, then certainly we take kids with minor illnesses, dehydrations, those sort of things very seriously, and would probably postpone them more readily than we would postpone a child without mitochondrial disease. So I think those are just sort of the things to sorry, to be open and honest with your surgeon, your anesthesiologist, and your team prior to surgery.
Okay. Thank you. So you kind of just went over that first point, avoid preoperative fasting if possible, and if fasting is necessary, try to limit the period to only overnight or the shortest necessary interval. So you made an excellent point, right? It depends on what is that meal and then how many hours is it. I think it's also going to depend on, like, is this somebody that has severe gastroparesis, right? Because what we really are looking for is the stomach needs to be empty, right? Because the whole reason to be MPO is so that you don't vomit from the anesthetic and then have a risk of aspiration, right? That's the really important point here. And so we have to make sure we know what the content is of what you're eating. And again, we want to avoid vomiting, nausea, vomiting, and aspiration of the contents that are in your stomach for the procedure. During prolonged preoperative fasting, IV fluids with sugar, right? Dextrose should be provided. And we just talked about consider omitting the night prior if you're medically fragile or prolonged fasting is required, especially if you're prone to hypoglycemia. The next thing that we talk about a lot is what should these IV fluids be, right? Because I've heard everything from D5, D10, D20, D50. And I think we've had a long-standing concern in the mitochondrial field of lactated ringers. And there are some patients with mitochondrial disease that have an elevated lactate, but there are for sure many patients that don't have an elevated lactate, right? Not everyone has elevated lactate. And lactate is actually not something that's dangerous, right? There's elevated lactate, and then there's something that we call lactic acidosis. And it's the acidosis part of that equation that can be harmful. So if your lactate is 4, but you're not acidotic, meaning your pH of your blood is normal, your bicarb is 19, you're not doing your body any harm by having a lactate of 4. But what that tells us that your lactate is 4 is that you're not using lactate as a sugar to serve your body. And so if somebody then wants to give you lactated ringers, lactate as a sugar to serve instead of dextrose, you might not be able to utilize that lactate. So somebody who has an elevated lactate, we kind of pause and say, lactated ringers might not be the best sugar solution to give this person because they're not utilizing lactate. But what I've heard from my friends like Dr. Kilbaugh is that there are actually times in the world of anesthesia and ICU where lactated ringers is actually the preferred IV solution, and in some cases, the life-saving solution. And so I never want to be in a position as a child neurologist where I'm interfering with life-saving measures from the team that can save a life. And so I need to be very cautious of making recommendations where I need to know my place and say, there's a risk versus benefit here. And if lactated ringers is the preferred fluid, I need to step back and say, they need to make this decision. And I'd like Dr. Kilbaugh to talk about that a little bit more.
Sure. So for me, there's a couple different things. One, I'm not that afraid of lactated ringers in kids with mitochondrial disease because it's not actually biologically active lactate. So it's not going to, as Amy said, it's not going to lead to an acidosis. What I am sometimes worried about is when these kids actually get a lot of normal saline. Normal saline has a lot of chloride in it. And what ends up happening with these kids is they actually end up with a hyperchloremic acidosis. It can actually make them worse by just avoiding lactated ringers or a balanced salt solution. So it's important that when your child is in the intensive care unit or they're in the operating room, that the anesthesiologist or the intensivist is thinking about their acidosis, which is really their major issue. And so as they have other problems with their electron transport chain or creating reactive oxygenation species and they become more and more acidotic, it's more important to have a balanced salt solution than it is to really avoid lactated ringers. I know this is sometimes something that causes a lot of anxiety for parents, especially since they've been told for so many years that their child shouldn't receive lactated ringers. But I assure you, it's more about their acidosis than it is about whether it's lactate or whether it's sodium chloride or other sort of solutions that are things called Normasol, which have a more balanced sodium and chloride in them that lead to less swings in their chloride level. So I think ultimately what's the most important thing is that the anesthesiologist or the intensivist is really checking their getting labs on them more frequently in the operating room. Sometimes we almost rarely draw electrolytes in the operating room, but kids with mitochondrial disease, if they're having a long surgery, those are the kids that I'm always checking lots of labs. I'm looking at their sodium levels, their chloride levels, their acidosis, what their pH is on a regular basis, what their overall lactate is, and is that contributing to their acidosis. It goes into the part of a more complex sort of algorithm for that in particular patient. But lactated ringers is not something that I generally avoid unless that I will avoid just altogether just because the child has mitochondrial disease. I'm more concerned about what their acidosis is doing during the stressful period of the anesthetic and surgery.
That's wonderful. Thank you very much for helping to answer that question. And I'll just add, I've had a few patients that have had high lactates, and when we've given them glucose or dextrose containing fluids, the more dextrose we gave them, actually, the worse the lactate got, and the more it rose, because the dextrose gets converted into lactate, and the higher the lactate gets, the more acidosis you get. And so actually the higher the D, right, you go from D5 to D10 to D15, you can create more lactic acidosis. So again, the fluid selection, we do think about it very carefully. And I really appreciate what Dr. Kilbaugh just said. You know, we've learned a lot about lactated ringers and when not to use it. And there's I think we've learned that it's not as dangerous as was once thought, and it does not have to be on the do not use list. And I still see it on the do not use list, but I think we've determined that it can be used quite safely, and in some cases may be preferred over other fluids. I think the next hot topic that we can talk about is propofol. And many of us put this on our anesthesia letters, that we do not want to use propofol in a prolonged way. And prolonged means more than an hour. So prolonged use of propofol should be avoided, but we can use that during induction, meaning if it's less than an hour, to help somebody get into that anesthetic mode, but not to use it for the whole case, that propofol can be used. And I think that the one caveat I would say for me is that I've had a few patients that look like they've had propofol infusion syndrome, that have a mitochondrial disease. And I think it can be a little hard to say if it was just a high lactate that ended up resulting after someone received propofol. So I was going to ask you about that. Should propofol ever be completely contraindicated? Is it okay to use it during induction, and what your thoughts are about using it for a whole case? And I'm going to add one more caveat. There are children and adults that have fatty acid oxidation disorders, and we know propofol is contraindicated for patients with fatty acid oxidation disorders because it does interfere with fatty acid oxidation. So now I will ask you to please answer questions about propofol.
Yeah, no, I'm really glad that you brought up the fatty acid oxidation, because I mean that those are the patients that it truly is contraindicated for. Everything else becomes a bit of a gray area after that for me. I know that when I'm also a mitochondrial researcher, so I do a lot of mitochondrial research as well. And when we've looked at it hasn't been done as much in large animals, but when we've looked at mice that have mitochondrial disorders and varying degrees of whether that's from antioxidant or complex 1 dysfunction, we know that almost all anesthetics inhibit complex 1, almost all of them. And take your pick: ketamine, propofol, dexmedetomidine, volatile anesthetics. Some of them affected in a bit more profound way, like volatile anesthetics, and potentially propofol. But when we've looked at it in the past, it's unclear how much propofol causes more complex 1 dysfunction than the other anesthetics. So I think it's safe to use propofol for this less than 1 hour period, or for short procedures. Like if you are having a short colonoscopy or something like that, I think propofol is still a fairly safe drug. It's a very good drug. It's very tolerated especially by patients that have other issues and other physiologic sort of comorbidities as well. I think the other thing is anesthesiologists use it a lot. So if you're in a center that's not necessarily like some high-end center that is used to taking care of kids or adults with mitochondrial disease, sometimes when we come up with all these rules, we tend to take away, the tools that that particular practitioner uses all the time. And when they have to use something different, it makes it a little bit more difficult for them to provide care. But I like the number 4, the prolonged use greater than an hour propofol should be avoided. It is a very good induction medication. It's a very good maintenance medication for anesthesia. But now in the world of that, we can use things like dexmedetomidine, for example. Ketamine is another example of a drug that we can use in combination with the dexmedetomidine. I think for longer procedures now, especially if we're doing like big ortho cases with a child with mitochondrial disease, I will often induce with propofol. I will use a opioid or a narcotic such as fentanyl or sufentanil infusion for pain control, and then a combination of ketamine and dexmedetomidine as their overall anesthetics. And these are very well tolerated by these kids. And they actually may have a little bit more benefit than propofol too in some of these kids because they're probably a little more cardio stable. And what I mean by that is they tend to maintain cardiac output a little bit better than propofol does over a longer period of time. But it still means that I think the overall summary is that you can safely anesthetize patients with mitochondrial disease using a lot of different things as long as you are paying very close attention to them. If it's a long case, make sure that you are drawing laboratory values, you are aware of all their other comorbidities as well, and you truly understand the disease. And certainly anyone with fatty fatty acid problem should not be using propofol at all.
Great, thank you. And then my next word of advice is to please schedule procedures to be performed early in the day. And again, I think that's just to avoid kind of that bumping phenomenon, which may not happen a lot, but it could happen at other places. And again, I think you made a comment that if cases get bumped, you try to preferentially not have that happen to the children with mitochondrial disease at our hospital, because again, I just don't want things to get bumped to the point where we have somebody who's been fasting for too long or other situations. So is that a reasonable thing for me to be including on my letter? Does that convey what I think it's trying to convey, which is that I don't want that kid sitting there all day and they get forgotten and no one's putting an IV in them?
Yep.
Okay.
We almost always try to make them the first case of the day.
Okay, great.
Absolutely.
Okay, great. Thank you. And then is there anything else that I could be including in my letter that would help again with kind of just overall recovery? Because we're trying to really covered the entire perioperative period here. And this is a lot of preoperative advice, right? But we really want to make sure that, the case goes well and that the recovery goes well. You said something that kind of reminded me of one of the other things I think about, and that's for long orthopedic surgery, right? So if there's like a big scoliosis surgery or something like that, or even children that come in and they're already like a little anemic. I think about cases that are going to involve like some potentially big blood losses. I think about our cutoff for, when would we recommend a transfusion, and should it be a little earlier for somebody with mitochondrial disease? And I just think about, they're already going to be struggling maybe a little bit with recovery. So should we be having people get a transfusion a little bit sooner so that they're not also fighting the anemia as they recover? And this goes like, maybe a little bit beyond, my scope certainly, and maybe your scope as an anesthesiologist, but I really, the hematologists don't like this question either, to be honest with you. So I feel like the cutoff that we use is maybe like a hemoglobin of 7, and then we start thinking about a transfusion. But I've kind of wondered, like, should we be using a hemoglobin of 9? Anything below that is the cutoff, because I've seen kids 6 months after scoliosis repair, and they drop down to a hemoglobin of, let's say, 8.5, didn't get transfused, and then it's like, oh, and this took forever for this kid to get better. So I'm just, kind of starting to wonder, like, is there anything else we can do with the post-op recovery is one of my questions. And is there anything about blood loss or hemoglobin or rehab or, anything else that we should be thinking about perioperatively?
Well, I think a couple of things. One, so since I do ICU and anesthesia, I see these kids both in the operating room, and then I see them afterwards too. I think the important piece is to understand that these kids take longer to recover. So making sure that everyone is on the same page, as a parent, I would want to make sure that my entire team is on the same page about where this kid should be recovered after their surgery, depending on what type of case they have. Um, Many of kids can have short procedures and they go home later that day. I think usually we try to keep these kids at least for a night to make sure to see how they're doing. Certainly, I have a very low threshold of sending these kids to a kid to the ICU for, sorry, more intensive monitoring. Whether that's from a lab perspective or from a nursing perspective or just from close ICU monitoring in terms of monitoring their physiology. When it comes to sort of going off of sort of what we normally recommend for other kids in terms of, let's just say, um, um, blood products, I'm not sure there's a lot of data to suggest that a child that has a hemoglobin of 7 versus a hemoglobin of 9, whether they have mitochondrial disease or not, is going to lead to them to be better in months ahead of time, or even weeks ahead of time, or even days ahead of time. So I get a little bit nervous about sort of practicing outside of, well, I just kind of feel like this may feel better for them. But what I do feel is that we need to treat these kids like we do other kids, and we need to get them up and moving. We need to provide good physical therapy, occupational therapy early nutrition, all the things that we do know that helps all children or all adults recover from a major surgery. And I think sometimes because kids have mitochondrial disease, and it's not just mitochondrial disease, I would say kids that have other comorbidities before surgery, sometimes we're a little reluctant to sort of, go into boot camp mode after a surgery and sort of start moving them forward because we think they're fragile. And yes, that may be some of the case, but it's more important to get these kids back on their medications, back on their nutrition, back into physical therapy, doing those type of things, because they're all going to have a longer timeline to recovery from anesthesia. We know that. I don't think we truly understand why that is, for the most part, other than general myopathies and some of the underlying disease process. But how anesthesia actually affects mitochondria, I wouldn't say we totally understand all those mechanisms. And so, but it's very true these kids take longer to recover. But my big thing when these kids are in our ICU is that I don't want to just rest on the fact that it takes longer for them to recover and then just sit on them. I think it's important to really try to push them with nutrition and physical therapy and those sort of things and treat them like a normal child, because I think that actually is the thing that reduces that time window for them to get out of the ICU and towards recovery. So I know it's kind of a wishy-washy answer on the hemoglobin. But for me, I don't treat it any differently because I don't think oxygen carrying capacity in these kids, when I just think about it as a biochemical sort of process, depending on what type of mitochondrial disorder they have, I don't think that's necessarily their issue. I think this is a much deeper issue and not necessarily about how many grams per deciliter of oxygen each hemoglobin moiety can carry. I think this is something else. And if you come out of these surgeries and you've really thought about their acidosis and the way that their the electron transport chain and all those things can work really in tune with each other, I think those are some of the things that are more important. When are they getting what glucose do they have? Right? Have you kept their glucose at a normal level, 80 to 120 or something like that? Have you managed to give them enough fluid so that they have good perfusion into their organs and their lactic acidosis stays low, but at the same time, because their heart doesn't work as well and all these other things that you don't fluid overload them so their lungs are wet. It's more of the delicate ballet in the operating room into those first 24 to 48 hours of care that is the most important, whether it's a particular lab value or not. I'm not sure it is. They're just beautifully complex children that need really close observation and a lot of care.
Mhm. I think that was a great answer. And, I love how you answered that. We don't have data. And so I might have some hypotheses, but until we have data, we don't know if what's the right thing to do. And so I'm gonna hit you with my next hypothesis, which is that you mentioned nutrition, and I love that you stressed it. I think you mentioned it 3 times. Sometimes one of the biggest challenges we have is getting the gut to move again after anesthesia, right? And these kids and adults have a lot of gut issues, so gastroparesis and dysmotility, and then you add anesthesia, or you add sometimes we need pain management and narcotics early on after surgery, and that can also slow down the gut. And so sometimes getting the enteral nutrition going again can be delayed, right? We've got post-op ileus issues and all of that. And so what happens if somebody cannot get their enteral nutrition going again and they're on IV fluids? Do you think we can start TPN a little sooner in this population so we can get some protein going and we're not just existing on carbohydrate?
Well, that was just sort of a setup question because my answer is going to be 100% yes. And I think that's part of, especially for kids having longer, bigger surgeries, that's something that I think that is a very critical part of the first 24 hours, is that as they sort of go through this catabolic state, after having a massive surgery with tissue planes and breakdown of muscle and all these other things, early parental nutrition is absolutely critical. And I'm talking like the day one post-op is for us, TPN get started. We work very closely with the nutritionist, the mitochondrial team, those sort of things. It is not something most kids, quite honestly, that don't have mitochondrial disease, if they're not fed for a few days, they're fine. These kids are not. These are the kids that right away, they again, keeping things simple post-op for them is nutrition, physical therapy, problems with gut and gut motility, doing things like when they can, if they can get some type of physical therapy, sitting up on the side of the bed, if they are able to, even moving just muscles around passively with the help of his physical therapist or the parents, like sort of doing some things, incentive spirometry if they're not trached and vented, those type of things, all these sort of very basic approaches can really reduce the amount of time that they're there. Because GI dysmotility, quite honestly, if anesthesia goes well and the early post-operative period goes well, it's almost always our biggest problem. It's the thing that keeps them in the hospital for more and more, because especially if they've had a big surgery and they've had pain, they tend to get opioids, which are necessary, absolutely, and they should receive those things because that's important as well. But it's usually when their gut will come back and they can tolerate feeds.
Great. Okay. So I just want to show an example of one other letter. So again, this is kind of our CHOP recommendations. And then Dr. Koenig allowed me to show the letter that she provides from UT Houston from their Mitochondrial Center of Excellence. And it's very similar with a couple of other things. So she talks about all the things, all the manifestations that people can have with a mitochondrial disorder and what kind of adverse events have happened. And she talks about propofol and how it has been used successfully in some cases. So we need to consider what agents should be used in the context of any one patient's history. And it's important to remember that the absence of published reports of adverse events with an agent does not mean that the agent is safe. But this being said, here are the anesthesia precautions. So keep MPO status to a minimum, and we've talked about that. And we've talked about whether or not somebody should be admitted the night before for IV fluids. Now, her letter says ringer lactate should not be used because it can precipitate or exacerbate lactic acidosis. And again, we've talked about that. And, she and I both participate in the Mitochondrial Medicine Society. And again, if there's some dispute or some confusion. And I think this frustrates the community, and for that, we apologize. We don't want to be saying different things because I think it gets frustrating. And so if there's ever times where you're seeing different things from different centers or different doctors, we do want to, as much as we can, have some consensus on these guidelines. Propofol should not be used, and here's why. And again, they don't have a caveat in their letter about it's okay to use it for short term. It just says don't use it, which again, we have a statement that it can be used for short term. They call out some of the medications that they feel can be used. Ketamine, Versed, Precedex, which we've talked about, can be used as appropriate. And I will just say that, we have a couple of patients that say, I've used that and that didn't work well for me. And for sure, any one person's bad response to any drug should be taken into consideration, right? So again, we always want to take into account the individual response to anyone. She is mentioning something Dr. Kilbaugh already talked about, which is complex 1 inhibition. And that's happened with all of the anesthetics, that we know they inhibit complex 1. And I don't think that means that we do anything different with patients with complex 1 deficiencies per se. It just means that we have to be careful with anesthesia and mitochondrial disease, which is the purpose of these letters. But they say Precedex is the agent of choice. Inhalation agents, including SIVO, which we call sevoflurane, can be used at the discretion of the anesthesiologist. And again, even when I have a letter, we talk very often about what is the best medication for this particular case, for this particular patient. And I have many conversations with our anesthesia team about devising a plan specific to that patient. I do want to bring up the next line that she talks about. Although the risk of malignant hyperthermia is questionable, succinylcholine should not be used. And there is a lot out there about malignant hyperthermia, especially from the Newcastle group in the UK. Malignant hyperthermia is not related to mitochondrial disease. It is a separate genetic problem. It's on the RYR1 gene. It's not a mitochondrial disease. It happens after getting certain anesthetics, especially muscular blockade, such as succinylcholine, a paralytic, where you can develop a very high fever, rhabdomyolysis. It's an emergency. And so people do need to know about it if you've had that experience or there's a family history of it. But I've seen people have in letters, if you have a mitochondrial myopathy, treat it like malignant hyperthermia. And again, I think there's times where muscular blockade may be part of what the anesthesia team wants to use for the case. And I'm just going to pause here and check in with Dr. Kilbaugh. How often do you want to use succinylcholine during a case? And does this get confusing for the anesthesia team, or really limit what you can use if you're trying to use mito precautions and MH precautions in the same case? Does this get tricky?
No, not at all.
Okay, good.
I think if people, if there's a concern about that it's very, succinylcholine is rarely used anymore because of newer non-depolarizing agents. And there are reversal agents for those now that are commonly available here in the United States. So there's no real concern to safety or the real efficacy of the choices that we can use if volatile anesthetics and or succinylcholine are taken out of the mix. That's totally fine.
We didn't really talk about volatile anesthetics. Do you want to say anything about those?
Yeah, so for me, obviously, if someone has an MH risk or they have a concern that they have an MH risk, we wouldn't use them, much like succinylcholine. But it's clear that volatile anesthetics like sevoflurane have been used in kids with mitochondrial disease for many, 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 many years, and have a wide safety profile. There are some families that come in that I've taken care of that have requested not to use a volatile anesthetic. And depending on what we're doing in those sort of things, I don't really have that much of a problem with it, because I think you can use a combination of ketamine and dexmedetomidine as your basic anesthetic with some type of other types of pain control. So I'm okay with that. But I would, in those patients, usually use propofol to induce them or to get them off to sleep very early on, and then switch over to all those medications. But I don't have any problems with mitochondrial kid having an inhaled anesthetic.
Thank you. Okay, and then they recommend perioperative monitoring of labs as is indicated, and then normothermia should be maintained. And I think that's, it's, great. We don't want somebody too hot. We don't want them freezing and shivering. I just want to say perioperative monitoring for us, pH is probably reasonable in the OR, I would think, glucose, right? Because you've got some stat meters where you can do that. Lactate probably can come off of a stat meter. Pyruvate certainly cannot come off of a stat meter. That's usually something that goes to the lab and we get it 3 days later. So that's not really something that we can measure quickly. And then you mentioned electrolytes are something that are not typically done in the OR, but could be done if necessary. Right. And especially if somebody's getting fluid where you think chloride needs to be looked at or sodium needs to be looked at, it's something that you could do.
And the common point of care
Mhm.
instruments that we have now in the operating room can give us electrolytes as well as pH, glucose, and lactate. But absolutely, we can't get pyruvate.
Yes, exactly. Okay. And then I think we are already at 7:45, close to it. So I think what we're going to do, I had a couple examples for other letters, but I think what I want to do is start going to the questions because it looks like we've got 22 questions in the Q&A. Margaret, did you want me to kind of open up the Q&A or did you want to read some out to us? How did you want me to do that?
I'm trying to come off camera so I can talk. I'm happy to go through and kind of pull some of them together that I think are similar.
Okay, I
There
think
was
that would
one
be
really
great.
specific one that I would love answered because I couldn't catch it either. Let me find it. It was what is the anesthesia Dr. Kilba referred to? It sounded like dexmedetomidine. Can you maybe type that answer into the Q&A? Dr. Kilba,
Yeah, and it's actually right here.
Yes,
It's
that's the one.
the trade name is called Precedex.
Okay.
And I'll let him try to pronounce it again. This is why I'm not an anesthesiologist because I can't pronounce the generic names of their drugs. Dexmedetomidine. Did I get it right?
Dexmedetomidine, and I put it in the Q&A.
Oh, perfect. So everyone can go there. There are a lot of questions about precautions that people should take surrounding dental procedures. Can you talk a little bit about that? That's something I think would ease a lot of people's minds. I know they think about it before they go and they're worried.
No, go ahead.
You can go ahead, Amy.
Well, so for better or for worse, I have a little bit of a particular bias with dental procedures, and I get a lot of people that send me forms saying, could you please sign off on this dental procedure, which is being done in an outpatient office where somebody wants to put my child to sleep in an outpatient office. And I just picture a strip mall somewhere, not in my hospital. And this scares me, and I'll just be very honest about it. I want my patients being taken care of in my hospital, and it's incredibly biased of me to say that, but I don't know who's putting your child to sleep in your private dental office. I want my anesthesiologist putting your child to sleep where I know that they're going to be safe and that all of these precautions that we've put so much time into, that they're going to be in safe hands. Now, having said all of that, if it's an adult or an older child where we just need a little lidocaine or novocaine to numb up a little local area so you can have a cavity filled, I don't have a problem with local anesthesia. I have a problem with even nitrous. And again, I'll let Dr. Kilbot answer that. But if we're talking about conscious sedation or more outpatient, I don't approve that. I say you're going to need to come see our dental team and have this done in-house, because I don't want anything bad happening to one of my patients outside of the hospital. And that's from a very bad experience that I had with one patient, and I won't ever do that again.
Yeah, I think I agree with Amy. I think so first of all, I think if it's an adult, so first of all, I have no problems with local anesthetic. I personally don't like nitrous oxide for any patient, whether they have mitochondrial disease or not. And we don't actually have it in the hospital, and we don't give it. And that's a hour-long discussion in unto itself. But I don't I wouldn't let my kids have nitrous oxide at a dental office. I think there are some dental practices that have anesthesiologists associated with them. And especially if you're an adult, I would, if you want to have it done there because you have a particular provider, I think it's something that you need to have a very good conversation with the anesthesia team at that dental practice, and make sure that they've taken care of patients with mitochondrial disorders and they have a clear and cogent plan and can even work with your primary mitochondrial physician as well. But in general, these are the type of procedures that if you do have to have sort of oral maxillofacial surgery, I would suggest that that's better done at a tertiary center that handles patients with mitochondrial disease than to have that done in someone's office.
Well, thank you. Quick question. If you were, if a person was in a community where they did not have access to any mitochondrial specialist, is there a specific resource that you might point them to?
Well, so for one, I think all of the clinical guidelines that we have are, at least for CHOP, are available online. They're not proprietary, so you can go to the CHOP website and get those things. As for other institutions, I think this is probably the same. But a lot of these sort of general guidelines can be available on at least the CHOP website for sure.
And I will, that kind of prompted me, I'll go to some of the other slides that I have. This is available on the internet. If you type in CHOP Mito pathway, this is available for doctors, medical teams, anyone who wants to look at this. It says emergency department and inpatient clinical pathway for the management of mitochondrial disease. And there are lots of places for people to click, but it basically can give a quick rundown for the emergency room or the floor or the ICU, even urgent care, to figure out who is a patient with mitochondrial disease, what are the symptoms that they might present with, and what should we be looking for, how do we manage things, how do we give IV fluids. And, you know, it's kind of a one-stop shop for somebody who may or may not be familiar with mitochondrial disease. That's linked to other papers. And then again, it defines what the stressors are. And then if I just go to the next page again, for the ER or for inpatient management, how to do IV fluids, how to treat metabolic acidosis, for metabolic stroke, how to give arginine or consider steroids, how we deal with status epilepticus or migraine, what do we do for liver failure. So this has really helped us to help our inpatient teams, but it is available for anybody to use outside of our hospital. So as Dr. Kilbaugh said, some of our guidelines are publicly available, and this links to other pathways. So again, seizure pathway, migraine pathway. So CHOP has a lot of publicly available clinical pathways. So do a lot of other hospitals. And then also other resources include the resources that are on the UMDF. Mito University has a lot of lectures. And then there's also the doc on call, right? So there's other, if there's a doctor that doesn't know a lot about mitochondrial disease that wants to talk to a specialist for a patient on a patient's behalf, then a lot of us are available through the UMDF to answer questions.
All right. This is a question that I hear pretty frequently, so I'd like us to cover it. How does a family get to speak to the anesthesiologist in advance of their appointment? Some places don't have a built-in system for that. And what would you recommend that a patient family do in order to assure that they have completely shared all of their information with everyone that's going to be involved in their surgical procedure?
Well, most, almost all programs have a perioperative medicine group or anesthesia resource center that you should be able to get to talk to an anesthesiologist before you have a procedure, or at least a nurse practitioner that works with the anesthesiologist before you have a procedure. It's actually the day before surgery. It's actually required for most of us to call and ask patients whether they have any issues or concerns for the next day. For someone that has a more complicated history, it's always important to try to work with your primary care physicians and especially your surgeon. If you're getting booked for a surgery, I would say the cheat code in any hospital to get to anesthesia is to talk to your surgeon and say, listen, my child or myself has a particular issue that I need to talk to somebody before I have surgery, or I'm not going to do it. Um, and if you do that, that surgeon in that surgeon's office will get you in touch with someone. So if you're having a hard time, I would go through your surgeon to make sure that you can get in touch with an anesthesiologist. But I think it's critical that you have these conversations up front. But again, like a place like CHOP, a place like University of Texas, most of these major centers, we all have anesthesia perioperative teams that are there to answer questions and to make sure that there's a full cohesive plan going into surgery.
Thank you. Is there a fluid protocol for post-op recovery? Well, what would you recommend for that for most people?
Yeah, I mean, I think it's if to maintain hydration, they need glucose in their fluids, but your glucose needs to be checked, right? So how much glucose is dependent on what a patient's glucose is, and that can be modulated over time. But certainly, um, most of these patients come out on maintenance fluids, and then like we discussed earlier, we'd want to switch to some type of parental nutrition if they can't tolerate enteral nutrition fairly quickly.
On the topic of fluids, this was a question I thought was interesting. What do we, what should we have fluids while fasting, but we have a heart issue and they don't want to get too much fluids? How do they
Yeah.
balance that? How do they figure that out?
I saw that question too. It was a good one. So I think this is a really critical, again, this is sort of a cheat answer, but it's just actually the truth. You need a good anesthesiologist. You need people that take care of patients that are complex. Because I'm not going to give you a succinct answer in one step because that really depends on that patient's sort of what their heart dysfunction's like. If they, what type of dysfunction? Is it global? Is it just their left ventricle? Is it their right ventricle? Do they have valvular problems? Is it a child with mitochondrial disease that tends to have just lower cardiac output from cardiomyopathies? Those are all things that are absolutely critical to watch. And I might be much more, um, I, I would be more conservative with the amount of fluid that I would give them. And back to Amy's question, that might be a patient where I would make their hemoglobin 8 to 10 and not use as much crystalloid and use things that like more colloid based fluids like blood or FFP or other things that I know depending on what their cardiac disease is, depending on what their renal disease is. So these are complex kids that don't follow the rules. Anybody that's on here is here because they understand that these kids are complex. We know more and more about them every year, but really, most of the knowledge that we've gained about these kids has really been in the last decade. And we're just starting to catch up on so much of this, especially when they're critically ill and when they're in the operating room, which is something we just haven't studied that much. It's been something that's even in the literature we've kind of not ignored, but just hasn't really been a deep foundation of knowledge for these kids yet. So it takes really adroit, smart people that are thinking about these kids in a really multidisciplinary way. It's why I like working where I work because I can pick up the phone and call the mitochondrial team at any time, whether I'm an ICU doctor or an anesthesiologist, and start just thinking things through, because you can see Amy and I don't have solid answers on some of these things because it's not just the cookbook. We're not just flipping open to page 73 and saying, okay, we're going to do this. Many times when these kids in the postoperative period, especially if they have other comorbidities, we're just sort of robbing Peter to pay Paul a lot and trying to figure out how we can balance what we're doing in that moment to make to hope for the best outcome possible. So I think it's a cheat, but it's just true. You need to go to a good center. You need to have good primary doctors around you that are invested in the care, that are talking to the anesthesiologist. The surgeons need to be aware of the risks and be invested in that case, and not just, okay, well, we're just going to do this case because it's just a G tube, or we're just going to do this orthopedic case. They need to know that needs to be the first case. They need to know that these kids will go to the ICU afterwards. They need to know that about the consultants that they're going to need around their care. And you really need to have everybody on the same page. And when you have that, these kids do well. And when you don't, they don't. And that's the really important thing.
And the recording of this session today will be available to all of our patient families, and I encourage you to make sure that you share that with your primary care physician. There's one other question I want to get to, and I'm kind of combining some. Gastroparesis and constipation after anesthesia. How do people deal with that? What should they plan for? And any recommendations you might have.
Yeah, this is a common problem for all people. But especially for children that suffer mitochondrial disease, or adults that suffer from mitochondrial disease for that matter. So very important. If you have a surgery that's going to require you to be on opioids afterwards for pain medication, you need to be on some type of stool softener right away. And you need to be on some, potentially even some promotilics, but certainly a stool softener. So things like Senna and some other things in the immediate post-operative period is critical. And then I think it's important to start parental nutrition, so IV nutrition pretty soon afterwards. But also, we usually try to start some type of a little bit of feeds, even if it's 1 to 2 cc's an hour, and see how much their gut will tolerate it with their particular type of enteral nutrition that they use. Because I do think that that helps the gut to sort of wake up a little bit, and also tends to bathe the lining of your gut so you don't lose as much of the good bacteria that tends to be in your gut. So as an ICU doctor, we start what's called our trophic feeds, or TROPHIC, very early. Even if it's 1 to 2 cc's an hour, I think that's also pretty important, and things that I would talk to my anesthesiologist and my ICU doctors afterwards. So I think it's important to be aware of it, stool softeners, early IV nutrition, and to think about early trophic feeds as well in these patients.
I think for the questions that we weren't able to answer today, we will be sending them out to the docs to get answers for them post-event. But I wanted to check in with you, Dr. G, if there was anything else that you thought our patient community really needed to hear today.
I'm just sitting back and enjoying everything that Dr. Kilbaugh has been saying, and just, I've been nodding my head like crazy and just really enjoying the conversation. I think we just brought up so many really important points. People asked amazing questions, really important questions, and the questions that we get really frequently. There's a lot of really common issues and a lot of common questions that center around this topic of anesthesia and care, that we call around the perioperative period. And as Dr. Kilbaugh said, we don't have all the answers. And we'd like to have all the answers, and we'll get there, hopefully. And, you know, one of the other things that, again, I'm still sitting here thinking about the difference between my letter and the letter between Dr. Koenig, and we're very close colleagues. And I struggle with wanting everything to be clear and nice and easy for our community, and struggling with the fact that we give inconsistent answers, and I don't like that. And so, again, trying to make sure that we have the best answers for everyone here, and that we give the best advice that we have based on, again, not just, anybody's whim or, what my feeling is of the day, but just, what the best science is and what we feel is going to keep our patients safe, and making sure that we can provide the best care possible. And to, if there are myths that are out there, that we correct them, right? That we make sure that people are also up to date on current thinking and the best scientific facts, and that we have experts like Dr. Kilba out there doing the research and making sure that, we can replace old thoughts with the current facts, and make sure that, again, our patients get the best care. Yeah, and I just want to thank everybody for attending, and because these calls get late, depending on where you live, but I was excited to be here right before Rare Disease Day. And Dr. Kilba, my goodness, showing up with a cold and everything. Thank you so much for sharing your knowledge with us, and entertaining all of my questions along with everybody else on the call. I really appreciate all your knowledge and your wisdom, and everything you shared with us tonight. It's
I have
great.
one quick question for you all. Can you, whoever's advancing the slides, so March 30th is National Doctors Day, and I think one of the blessings in the mitochondrial disease community is on full display here this evening, that we have the best doctors that care about our patients and are willing to be here in the evening. Just to learn a little bit about you and to celebrate you a little bit, can you tell us, let's start with Dr. Kilbach. What made you decide to become a doctor?
I the cheap answer is I played professional soccer after college, and had a bad injury and needed to do something with my life. So I thought medical school sounded great, and I kind of made the decision kind of on a whim, but it turned out to be the best decision I ever made. And I have been very, very fortunate to find something that I truly love. And really, 20 years ago, when I was a student, I became absolutely fascinated with mitochondria. And at that point, no one was really studying it at all. And I was actually interested in mitochondria at first, not because of kids or the quote unquote rare disease, but I was really interested in it because I thought these kids with rare disease have a lot to teach us about so much about medicine. And even as a student, even at Penn, I couldn't find anybody really that would mentor me in mitochondria. And I had to go into late at night into a lab that had some equipment at the veterinary school that I wanted to use, and they would only let me use it after 10 p.m. They would let me use it between 10 p.m. and 6 a.m. because that's when their PhDs weren't using it. So that really sort of started my absolute fascination with mitochondria and how important they are for us, how incredible these kids with rare disease, with mitochondrial disease are, the type of things that they can teach us in general about our own overall health. And so it's been just an absolute love affair ever since. So that's
Okay,
sort of
that's like the best story ever. And thank you. I didn't know that this question was going to elicit something that had so many facets. Dr. Goldstein, how about you?
Well, in high school, I fell in love with biology. And in college, I was a biology major, also a psychology major. But there's something about like the science about it, right? So you have to really like science and biology and all of that kind of stuff. What some people might call geeking out on it, right? Um, And then with all of that, I mean, the simple answers, I really like helping people. I like being with people. I like hearing their stories. And there's nothing like being in a room with a patient, a family, and just listening to them and being with them and hearing what they've been through and trying to help them and honoring that. I mean, it's just, part of me is there because I'm bearing witness to what they've been through and walking the journey with them and seeing what I can do for them.
Thank you so much. Everyone mark your calendars. Wednesday, March 27th, 7 to 8 p.m. We will be going over the results of the myopathy and gait assessments study that was conducted at the inaugural UMGF Clinical Research Pavilion at our conference last year. So many of you have participated in this study, and we're all excited to hear what was learned there. We encourage you all to, whenever you have an opportunity to participate in clinical research, to consider it, because it helps us all move forward. Again, thank you, Dr. Kilbaugh. Thank you, Dr. Goldstein, for a very interesting and very, very